treatment, data-driven management of inpatients with INOCA and MINOCA. So this is a previous slide, but I would like to emphasize the last line. 95% of the coronary circulation is comprised of microvessels. We look always into the epicardial vessels, wherein we forget to look into the microvasculature. The clinical importance of microvasculature. The major determinant of myocardial blood flow explains in part why anatomy cannot predict fractional flow reserve. Explains some discrepancies between non-hyperemic indices and FFR. Significant impact on prognosis. Critically important, especially in shock states. Possible target for new therapeutic agents. So this is the conundrum of microvascular angina, both MINOCA and INOCA. It comprises a huge subset, which includes cardiomyopathies, heart failure with preserved ejection fraction, infiltrative Takotsubo syndrome, and others. So, what is the importance? Both INOCA and MINOCA are associated with high risk of cardiac events. Therefore, aggressive intervention, that is both medical and therapeutic, is needed to reduce the risk and symptom burden. So, we have already seen the INOCA endotypes. The importance of this is it comprises many subtypes which has to be kept in mind during treatment. So, there is much knowledge gap exists in the pathogenesis and management of INOCA. And how often INOCA and coronary microvascular disease progress to heart failure with preserved ejection fraction, and what is the mechanistic pathway? These are all certain unanswered questions. Is there any novel provocative tests for earlier diagnosis and treatment of INOCA? Why are certain cardiovascular risk factors associated with coronary microvascular dysfunction in some patients but not in others? What are the clinical, therapeutic, and prognostic implications for using the classification-based and measures for non-obstructive CAD? And what is the importance of coronary flow reserve, myocardial perfusion reserve index, and PET in these patients? So this is once again the conundrum. And by measuring the coronary flow reserve and the index IMR, that is the index of myocardial resistance, a tailored therapeutic approach can be made in these patients. INOCA in some patients could be due to hypertrophic cardiomyopathy, myocarditis, aortic stenosis, and infiltrative cardiomyopathies, which could be very well missed. Because of the uncertainty of INOCA mechanisms, many clinicians now believe it is important to understand not only the epicardial patency, but also the microvascular. It can also be associated with systemic inflammatory conditions, autoimmune disorders like lupus, rheumatoid, and primary metabolic disorders. Therefore, a teamwork with even the rheumatologist is very important to treat such patients. So we can have in these patients isolated microvascular disease angina. It could be a mixture of microvascular and vasospastic angina, or a pure vasospastic angina, or a non-cardiac ailment. So this is how we approach this case. We differentiate between whether it's a microvascular, vasospastic, or a non-cardiac. So the INOCA specific therapies in one single slide is risk factor control along with beta blockers and calcium channel antagonists, then the non-traditional anti-ischemic drugs like ranolazine, xanthins, AC inhibitors, ivabradine, and nicorandil, drugs effective for nociception, especially the xanthins and the tricyclics, and interventions for refractory angina, which include spinal cord stimulation and EECP. So INOCA specific therapies, I would like to mention here that in refractory cases, EECP can be considered. And along with that, very important is lifestyle modification, including weight control, exercise, nutrition, and stress management. This is the algorithm. Now coming to, we have to remember MINOCA is not a benign and has a comparable outcome with acute MI, similar to acute MI. So here in MINOCA, in INOCA we have seen the subtypes. When coming to MINOCA, we have to understand the underlying pathology and treat accordingly. Whether it is due to plaque disruption, put them as routine drugs, DAPT, statins, ACE inhibitors and ARB, coronary spasm, calcium channel blockers and nitrates, thrombosis and embolism, anticoagulation and hematologist consultation, a SCAD, beta blocker and antiplatelets and statins. We have to consider if there is an element of atherosclerosis, avoid pregnancy and estrogen, microvascular dysfunction, evaluate for that, and if there is a supply-demand mismatch, for example like anemia and other so many conditions, treat and identify the cause. So this is the full spectrum. We could say that the epicardial coronaries are normal, but in a patient it is more difficult to evaluate such microvascular angina. This is the entire spectrum. So the therapeutic strategies for patients with MINOCA, there are many centers where there is limited access to magnetic resonance imaging as well as PCI or non-PCI capable centers. So there is paucity of controlled trial data on treatment of MINOCA, although there are many observational and registry studies which has pointed out, especially the Sweetheart study, which is one of the largest studies, which included 9,138 patients, and have stressed the importance of angiotensin receptor blockers, which play a key role in these patients with MINOCA and they found to be very efficient. And it has been proved that they indicate long-term beneficial effects in treatment with statins and ACE inhibitors in patients with MINOCA, a positive trend for beta blocker treatment, and a neutral effect for dual antiplatelet therapy. In this Sweetheart registry, they haven't included the exact criteria of ESC definition of MINOCA. That is the only disadvantage of this study. Now coming to the other studies which promote, which also, coming to the AHA guidelines, what do they say? Plaque rupture in patients with MINOCA, DAPT for 1 year, and single antiplatelet therapy for plaque rupture. Coming to coronary artery dissection and coronary embolism, as I've already discussed, I'll come to the last slide. The outcome of patients with MINOCA, the Sweetheart registry, is a systematic review of meta-analysis of 1,924 patients, and the all-cause mortality was 4.7%. There is increased severity of atherosclerosis and CRP in such patients, higher evidence of pericoronary fat index in such patients, and the core MICA trial has shown that lifestyle has been improved in such patients when properly treated. Metformin has got a great role, and this is the final slide. It is multimodality assessment of MINOCA etiology, subset of patients. It's very important, and main importance is, though they recover initially, the long-term follow-up of mortality, rehospitalization and disability and angina play a major role. Newer trials are coming on many of the herbs and other spinal cord stimulation as well as coronary sinus reduction. Thank you so much for the patience.